Excuse me, ladies and gentlemen, thank you for your patience in holding. We now have our presenters in conference. Please be aware that each of your line is in a listen-only mode. You may submit your questions electronically anytime by using the chat pod located to the right of your webinar platform. You may also download a copy of today's presentation using the Files pod located directly below the presentation. It is now my pleasure to turn the conference over to today's first presenter, Jen Braun.
Thanks, Katie. Hello, everyone, and welcome to our monthly webinar, our last one of the year. My name is Jen Braun, and I direct the AHA Team Training Program. We're excited to have you join us for our webinar, The Importance of Multidisciplinary Teams, How Project Firstline Can Support Your Facility's Infection Prevention and Control Training Needs. This webinar is being presented by the AHA and CDC and is a sneak peek for what you can expect at our upcoming Advancing Care Conference, which I'll share more here shortly. But first, before we get into it, just a few rules of engagement to highlight. So you can access audio by either dialing in through your phone or by listening through your computer speakers. If your internet is unstable, your best bet is dialing in through the phone, which the number and passcode can be found in the notes pod on the top right. All hyperlinks are live, so keep that in mind. And you can, like Katie said, download a copy of today's slides in the Files pod on the lower left. Finally, I will moderate a Q&A session with our speakers at the end. So if you have a question, please chat them in throughout. We're happy to offer free continuing education credits for our webinars. And so in order to claim your CE credit, you must create a Duke OneLink account. And so this is a one-time only setup. And so following the webinar today, you can text MARPUK to the number you see there to claim your credit, and we'll share this at the end of the webinar too, and the details are also in that notes pod on the top right. In terms of upcoming events, we have these monthly webinars on the second Wednesday of every month. Registration is now open for our January 12th webinar, which is another Advancing Care Conference sneak peek, which is on applying human-centered design to the improvement of healthcare. We have 2 upcoming virtual courses. If you've had some exposure to TeamSTEPPS and would like a refresher and a deeper dive into implementation, you can check out our TeamSTEPPS for Change Leaders and Champions. If you're looking for a TeamSTEPPS Master Training course, which is definitely for those who are novice or beginners to TeamSTEPPS, that course kicks off in late January. Early registration for our waitlist is currently underway, and remaining spots will open next week, so keep an eye out for that if that interests you. And additionally, we hope to bring back in-person courses, fingers crossed, starting in the spring and summer, so more to come on that. And as always, we have our online community platform called Mighty Network, which contains exclusive content. It's really a great way to connect with your peers across the country who are interested in not just TeamSTEPPS, but team training in general. Finally, we're really excited to bring everyone together in person for our March 7th through 9th Advancing Care Conference, which will take place in Chicago. If you've been to former TeamSTEPPS or AHA team training conferences, you'll see similar themes exist that surround team performance, quality and outcomes, well-being, and education and facilitation. We'll share more at the end of our call about this, but scholarships, which are funded by Project Firstline and the CDC, are available. So consider applying for that today, which will provide financial assistance for registration and travel costs. Also, if you're looking to get involved at the conference, we currently have our call for poster proposals underway, and the deadline to submit your proposal is January 7th. Okay, so with that, I would like to introduce our speakers today. Dr. Abigail Carlson is the Medical Officer for the Division of Healthcare Quality Promotion at the CDC, and Kristen Hayes, who is the Director of Clinical Quality here at the American Hospital Association. Both work on Project Firstline and will be presenting at the Advancing Care Conference, so this is meant to be a bit of a teaser or a primer on what you can expect this March. So Kristen, Abby, I'll turn it over to you.
Thanks so much, Jen. So just wanted to start out real quick with our objectives that we hope to cover today in the conversation, and really excited to have an interactive session Definitely add in any questions or comments that you have in the chat, and we'll get to them when we get to the section of questions. So I'm going to start out with just giving a little bit of overview of what is Project Firstline. Project Firstline really is a very unique collaborative. There's a number of partners that work on this in collaboration with the CDC, and it aims to support the broad healthcare workforce with innovative training to enhance the understanding of the science of infection. It's really that understanding of the why, understanding of the science of infection prevention. We do believe that successful infection prevention requires everyone to be empowered with knowledge that will help to keep them safe and others safe. Project Firstline recognizes that there's a significant diversity in the educational levels, the languages, the ethnicities, the professional cultures, professional roles, and et cetera, that exist across the healthcare workforce. Therefore, we cannot rely on just a one-size-fits-all approach to training or education, and this will require a varied approach in which core materials can be adapted to meet the educational needs of the workers. And it also must be grounded in adult learning practices. So in other words, at Project Firstline, we adapt our approaches. We don't ask the healthcare workforce to adapt their learning needs, really trying to meet people where they're at. So I'm going to start us out this morning by asking you to already chat and add some comments into the chat of what comes to mind when you hear infection control. What does that mean to you? And just give us some thoughts of what you think. And I'm going to open it up to Abby, my co-presenter here, can definitely jump in if you see something in the chat.
Yeah, thanks. Thank you, Kristen. I'm looking at immediately we got hand hygiene, which is actually a really great thing to top things off with, along with prevention. Infection control, going right to prevention, which is a huge part of what we do. NHSN, many of you are very familiar with that branch of our division that handles all of the data coming in from hospitals across the country. Lots of great ideas here. PPE, source control, keeping patients safe. Wonderful. Patient safety. Absolutely. So, you are all hitting on really great aspects here of what infection control is. And some of the things that come to mind right away are the things that I would expect to come to mind right away, right? The things that you are encountering every day in hospitals and healthcare in general. I see HAI. I don't know, Kristen, do you see others that are popping up to you?
No, I think you covered it. I mean, I think just some common threads that I really see with a lot of the things that we're seeing in the chat is just really understanding the basics. Even just the hand hygiene is a real basic piece of infection prevention, but that ultimate goal of keeping patients safe. And there's a lot that happens in between that to really make sure that it's successful.
Absolutely. And I see Philip has mentioned here at the bottom, barriers and enablers of best practices. So that's a huge issue. And I think we're going to get to that as we talk through today. And you'll see how we here at Project Firstline might frame some of that and how you might be able to use that framework to start thinking about ways you can get rid of the barriers and increase the enablers. Chain of infection, Pam, absolutely. The chain of infection is a big one. We at Project Firstline as well have started to think about it less as a chain and more as kind of elements that are all necessary, but that interact with each other. So it's not like you go backwards or forwards, which is why we avoid the chain a little bit, the linearity of it, but rather that all of those elements are kind of happening all at once in different pieces and go between each other. So thinking about it as a complex kind of series of events that lead to infection, but that if you take away any one of the elements that are necessary, the entire thing sort of falls apart, which is a really great thing. IT presence during construction, Nancy, that is a theme of infection prevention everywhere that we run into all the time. So these are wonderful to me what you all are thinking of in terms of what infection prevention means. And I'm sorry, I wasn't able to read off every one of them. But in the interest of time, I'm going to move on to the next slide if you don't mind. And so infection control is. So one of the things that you all didn't do, but that I often get from frontline healthcare workers, and also to some extent from leadership, is that infection control is policy. Infection control is our procedures. Some of them will go straight to, if you click on the next one, Kristen, we'll go to regulations. Infection control is the regulations we have to control infection. And then some people, if they're moving away from policy, procedure, regulations, will still say it's the guidelines that we use. And all of these are important, but if you think about it, none of these actually control infections. So if you have all of these pieces of paper, and they're all written out, and they're very nice, and they're sitting in a corner office somewhere, they aren't doing anything. And so that then leads to the question, well, what is infection control? What is it actually? And I actually, when I first struggled to define this, it was quite hard to come up with a definition that wasn't tautological. There were a lot of definitions that basically said infection control is the control of infection. And that really doesn't help us very much. And when you don't have a definition, again, this can be semantics a bit, but when you don't have a definition for something, it makes it difficult to then build out and say, what are we doing? If we're doing infection control and we don't know what infection control is, how do we do it, right? So it led to a lot of thinking on our part here at Project Firstline about how do we explain what infection control is to people. And we've gone from that into I wouldn't say a simplified version, but a little bit more of a model for how to think about infection control that can also somewhat serve as a definition. So next slide, please. So infection control for us started with the question, how do we prevent people from getting sick? Which really, when you talk about controlling infections, we're not talking about controlling germs. The goal is not to disinfect everything. The goal is not to sterilize the hospital environment, even if it could be done. The goal is to prevent people from getting sick. And that really, in the end, it's the harm that comes to people that matters to us. So infection control is our answer to this. So how do we prevent people from getting sick? And as you think about that, we came up with this series of steps, this model of system. So when people ask me what infection control is, I will say that infection control is the actions that we take, the systems that we put in place, and the culture of shared responsibility that we develop to prevent people from getting infected, from getting sick. So this model is, it's certainly not everything. There are certainly exceptions to it. It's certainly not tested or evidence-based in that setting, but it is one way of starting to think about what infection control should mean for a facility, for a practice, for even a small working group of people, and starting to, as you build out things, as you look towards implementing things in your facility, looking towards this model of, okay, what are the action parts of this? What are the systems parts of this? And what are the culture parts of this? And will those together prevent people from getting sick? So with that, Kristen, I will turn it over to you to talk a little bit more about Project Firstline and the role in the model.
Perfect. Yeah, and so just like springboarding off of what Abby had said is the Project Firstline family really has brought forward a slightly new approach of really thinking about a lot of the work that we do in infection control and ultimately keeping everyone safe within the healthcare setting. And that's what Project Firstline really brings to the table, really approaching this by sharing some innovative educational resources to address each one of these 3 pillars of this work that we're doing, to support the actions, to support the development of the systems, and to support that culture change that I think a number of us are really working to bring to the infection prevention that happens, really helping everyone to understand how they fit inside that large team, how they fit inside the puzzle of infection control, and really have a sense that they can help and support, and it's not just the infection preventionist's job to prevent infections, it's everyone's work. And so talking about, as I presented what is Project Firstline, what CDC as well as all of the partners across Project Firstline have really come up with a lot of really great resources that help people in this quick and busy environment that we're at. A number of easy handouts that could be grab and go that offer some great visuals for people to guide their actions, as well as the facilitator toolkit, and even going as deep as giving some session plans that really is almost a script of how to do a quick 5-minute, 20-minute training session, something that can happen at change of shift or anywhere. We also are getting out there in social media. CDC has a number of different resources, really, again, trying to attempt to meet people where they're at. When Project Firstline first started, Abby was on Facebook all the time and doing some discussions on some key concepts of, why are they important and what do I need to know in order to help me to do my job better. And then at AHA, we have also created a number of resources that are available on our web. One specifically is a TeamSTEPPS Toolkit. Communication and teamwork really spreads across all of the work that we do, but specifically in infection prevention, having some strong teamwork or strong communication skills can really be helpful. So this toolkit really does walk an individual through all of the TeamSTEPPS tools and helps you to learn how to use them. And then other specific tools that we have is focus in on the environmental services individuals that work in healthcare to give them very specific resources. And they could also be used by clinicians as well to really just understand the cleaning that is done in the healthcare environment. So, Abby, I think we were going to talk about how can infection prevention, just giving us something visual to anchor ourselves in, to really talk about these 3 pillars of action, systems, and culture.
Yeah, no, and this is, you guys are going to get a discussion between Kristen and I that we also want you to be very involved with, so please don't hesitate to ask questions as we go through this here. But looking at this code response analogy, what we wanted to do, and I'll take it to the next slide, please. What we wanted to do is to take this model, which seems sort of very frameworky, potentially esoteric, maybe not clear exactly how it all comes together, and apply it to something that we're very familiar with, which is a cardiac arrest code. So code blue response, essentially. And when we look at the code response under this model, it actually fits pretty well, and it can help us understand, what we're talking about and how these things break down as we apply it to infection control. So when you think about a code response, you think about it as actions that we're going to take, systems that we have in place, and then a culture of shared responsibility that we've developed in our facility to prevent people from dying. And what we're going to do now, Kristen and I are going to talk a little bit about how we see the code response in this framework and then how we would apply it to infection control. So to start off with, I'll turn it to you, Kristen. In terms of code response and actions and how you see that translating to ITC, what things come to mind for you?
Yeah, thanks, Abby, and definitely want to open it up to all of you too. Please feel free to add into the chat any of your thoughts. Wanted to spend a little bit of time of talking through, like, what are some examples of actions that happen in a code blue. Some of the things that happen in my head right away, I'm a nurse by background, so one of the things that I would do in every code was really trying to get that PIV access. And so, everybody drops everything and runs to the area of need. And so what are the different actions that happen in a code? And then I think also we wanted to create that dichotomy and look at what are the actions for infection prevention. So again, trying to create that bridge as we talk about something that's very concrete that all of us are very familiar with, is the code blue, but then what are the actions from an infection prevention point of view? And feel free to throw in the things that come to mind in the chat. Assigning roles.
Yeah. Absolutely.
And I'd say that could even happen in infection prevention as well as, in a code, assigning the roles, particularly if you have a number of patients that are on different precautions, and helping people to understand how we're going to maybe do some cohorting or different things like that.
Yep, and I look at those as, I almost look at those as systems, right? So this is where it gets a little tricky, but here's how I would think about it. When I think about actions in a code, I think about what are the specific things that are getting done that have a direct impact on whether or not the patient lives or dies. And that doesn't mean that the direct impact is more important than a less direct impact, but what is it that has a direct impact on whether the patient lives or dies? So I think that, I look at it and I think, well, there's defibrillation, right? There's putting in the IV. The IV matters. Doing the CPR and doing it correctly, correct CPR matters, right? And administering medication matters, right? And when I look at that and I think about, okay, what are the direct actions in infection prevention that matter, it goes back to a lot of what all of you identified right at the beginning. Cleaning your hands, putting on the PPE, putting on the source control, right? Those are clear behaviors, clear actions that lead to infection not being spread, right? And I think that you guys are going right away, in a good way. I'm actually very happy about this, but you're going right away to the system. So, for example, having roles in the team lead, that's a system that everybody set up before you even got to the code, right? The people on the code team, they knew that codes should have team leads and roles for people, right? And that assigning them should be part of the process. Now, that doesn't mean that that's also not an action, like the actual assigning of roles may indeed save the patient's life. So you can see that there are gray areas in here, but you can also say, do I have a system so that everybody knows what their job is when it comes to doing the actions that are going to prevent infection? Have I put that in place? Training on CPR is another great one. You have to do correct CPR in order to save the patient. You have to do correct PPE use in order to prevent the spread of infection. Have you done the training to make sure that those actions are done correctly? The training is kind of, it's adjacent to the model, as we showed you before. It's incorporated into every level. Somebody needs to know how to do these things, but is it there? Dana, you mentioned simulation, which, again, that's an education and training for action, right? Education and training for how do you do it correctly. I don't know. Do you have other thoughts, Kristen, on what we're seeing, what people are suggesting here?
The other thing that I wanted to highlight, too, that somebody, I believe Mary mentioned this, was speaking up. And I think that is really kind of an example of culture, that ability in a code for someone to speak up And I mean, even just the fact that it's a common culture that anyone can call a code. It doesn't have to be the physician. It can be anyone. It doesn't have to be the leader. It can be anyone. And supporting that. And then where are we sitting on the other side from infection prevention? Like what type of culture? I think early on I saw, and even in some of these comments I'm seeing too, like that culture that infection prevention is everybody's responsibility, and infection prevention is important all the time, not just when you have time for it or when things get busy that it falls to the wayside. And so that is, again, how can we approach each of those three pillars to really be inclusive and support each other too. They can, you know, you talked about how some of the systems and actions, there is a little bit of gray area that falls into place, but they also just continually, it's almost like that cycle that they all tend to support each other.
Exactly. No, I totally agree. And then I also get to one of the questions that that has been pre-submitted that you all asked, which is sharing effective ways to foster accountability and ownership so that staff are vested in prevention as well as in outcomes. And I think, again, this really goes to that culture aspect. And if you think about a code, everybody does drop everything. They buy into the idea that, you know, there's an emergency here and you need to show up. They buy into the idea that it's multidisciplinary, that yes, okay, you want the doctors and nurses there, but you also want the chaplain, you also want bed management, you also want security, you also, so, you know, the people who come to a code are, many of them are not the people who are doing the CPR and putting in the IVs, right? And yet we would say those people are essential for a reason, and that is a cultural change in institutions that make people say, yes, I as the bed management guru should be there. I as the chaplain should be there, and everybody will accept my presence there. You know, thinking about how you do that, it's a very complicated question. I will say just up front, culture change, and this is, I'm preaching to the choir, I know, but culture change is the hardest thing to do. In an institution, culture change is the hardest thing to do. And it actually, to my mind, is really integral with systems, right? So if you want to make a culture change, you have to have systems in place that support that change you want to make. So if you are telling everybody, you know, everybody should feel free to correct the hand hygiene compliance of everyone else. Everybody should, if they see somebody who doesn't do hand hygiene and they think they might be needed, you know, you should make sure that that person cleans their hands. Well, that's a huge culture shift, getting back to everybody being willing to speak up, being back to, you know, what are the standards of behavior going to be? And so you have to have a system in place where you say to everyone, if this happens to you, one, you should expect it to happen to you. Two, if it does, you're expected to respond appropriately and not, you know, not denigrate the staff members, not push back, How do you handle that? Everybody needs to be taught that in a brand new way. It's not easy. It's not going to come natural to anybody. And so are you building a system that teaches those behaviors, reinforces them, you know, deals with any conflict that might arise, embraces, you know, people speaking up? And that culture is taken ages to develop in, you know, in ORs, in patient safety, on the wards. It's still not where we want it to be. It will always be a work in progress. But I think that you know, it really speaks to how much of an issue this is and how far we are. You know, how far infection control is from OR team culture. How far infection control is from code team culture. There's a long way to go. But there's, you know, you can use similar approaches to what you've used in other places.
Absolutely. Yeah, I mean, the speaking up, I think, is a challenge, and I mean, having a culture that supports that. You know, Abby, you hit the nail on the head. It is hard. I think one of the other analogies that I've heard you say many times is, you know, could we get to the point that infection prevention is, or hand washing is approached the same way that like smoking in the hospital is? Like if you had, I mean, there was a time that smoking in the hospital happened all the time. There were lounges specifically, and then even just inpatient care areas, there was smoking that was allowed. And nowadays, if you walked into a hospital and you like pulled out a cigarette, I think there'd be people running from so many different corners to be like, "What are you doing? Like, cut that out," you know. But if you know, you see somebody walk into a room and not use the hand hygiene dispenser when they walk in, you know, are people running to say, "Hey, don't forget, you know, wash your hands when you enter a room." And so I think all of us know, and you know, you talk about, well, is it directly correlated? I mean, there's so much research out there that shows how hand hygiene keeps people safe and keeps infections from occurring. But yet we still are, you know, nervous, shy, worried about doing that, speaking up. And so I think that, you know, it's a movement that all of us within the profession can help to support. And like you said, all that reinforcement, is it happening? What else can we do from a systems point of view to support the actions that ultimately create the culture?
Yeah, and I think that Dana is, I see that you had entered a few questions here, and you know, what's the underlying reason for not making infection prevention a part of everything we do? It's a great question. I will say, so I have a lot of sympathy as a healthcare worker. I have a lot of sympathy for people trying to balance all of the things they have to do in their workday. And yeah, it is sort of a rhetorical question, but it's also a good question. It really is a good question. So, and the reason that I like the question is because I think we don't see it as part of care, right? That infection prevention, again, it's the rules, it's the regulations, it's the protocol, it's the things I have to do because that's what the policy is, right? It's not, I am caring for my patients by putting them on contact precautions. We don't see it that way. And I think medicine is naturally individual focused, and infection prevention is naturally facility focused. And those two things can come into conflict, right? But I think there is, from an infection prevention standpoint, there are a few things I would say. One, as a hospital epidemiologist, my attitude, or the one I at least attempted to hold to, was that everybody who walked in that building was my patient. And my goal as their doctor was to get them in the building and out of the building safely and with health, right? Without doing harm to them and making sure that they remain healthy throughout. As far as infection control was concerned, I couldn't do much about, you know, their heart or their orthopedics, but I can do something about their infection. So having that attitude of these people are all our patients, and that includes our staff. And so when you are doing things in infection control, they are part of your clinical care, not just for your individual patient, but for all other patients you take care of. Putting your MRSA patient on contact precautions is care for the patient who you are taking care of next door who's not MRSA colonized. You are caring for that patient by preventing yourself from bringing MRSA over to them, right? And I think that that idea that this is clinical care is a hard one for infection prevention to sort of break through on people, especially because there's a little bit of a hand washing is clinical care, PPE is clinical care, but it really is. And putting that focus back on the patient can be very, very helpful, right? And speaks well to healthcare practitioners because it puts them back in their frame of what they have control over. I'll say as well, and that was very provider-focused, but I think that applies to EVS. I think that applies to, you know, the clerical staff at the nurse's station. That applies to the people who are in the C-suite. That applies to everyone. For all of us, those are our patients and we are giving care. And that might be as simple as cleaning our hands, but that's care. So that's another cultural shift that you can make within an institution to try to get people to sort of embrace the idea that this is part of their normal job duties that needs to be balanced with those duties. So clearly it can't dominate at every moment, and you get that, you know.
Mm-hmm. Yeah, and Abby, I think I also wanted to highlight something else that Dana had put in her comments, and also potentially even create a bridge with a comment that just came in from Cindy. Dana had mentioned in her comment just that the normalized deviance of behavior that happens, you know, like let's use hand hygiene as an example, or that drift. That's another way that I've heard it talked about. And, you know, drift occurs when we as humans just have certain activities that we do over and over again. They tend to become mundane, and we see them as not dangerous. You know, just an example in our normal lives is, do we all stick to the speed limit? Like, there is a speed limit, and it's there for a reason, and do we always drive at the speed limit and never go over? I'm going to go out on a limb and say no. I think all of us have probably had some speeding at one point or time. And, you know, the reason that you do that again is because you do the action or have that experience and there aren't negative consequences. And so one way that I think in my own personal work that I've had some success in trying to prevent that drift or trying to readjust the drift when it happens is really involving all staff and understanding that why. You know, if there is a CLABSI that occurs, having the nurse at the bedside involved in really digging into what happened a couple of days before the diagnosis, really taking an active part in that drill down, so that it's just I have had experiences where it's an aha moment to really understand the complexity that happens as we get to that diagnosis of an infection, and looking at so many opportunities of where things could have been done differently. And so really engaging people, you know, again, creating that culture that everybody is important and bringing all the people to the table to do some of that lessons learned or helping, bringing them to help with moving forward from some of these different interactions.
No, absolutely. And I think that, you know, that in a way it brings me back to systems as I kind of listen to what you're saying, that it's essential in this. We're talking about, we want people to change their behavior. So we want them to do the action. We want to have them have an attitude where they want to do the action. But bridging that has to be in some ways on us as leaders, of saying, okay, do they have what they need to make this as easy as possible? Do they have what they need so that they feel that this culture shift is not just you know, words in the air coming from us, but that this is really reflected in the investments we're making in the system? When I think about systems, you know, another thing I'll give you, I'll go back to the code analogy because this is one where I really like this. So for a code, right, the things that you have for a code to happen are actually quite extensive. You have an emergency number that people call when there's a code, and it's usually different from your main number. You have a dedicated operator who will answer that line on priority. You have a team that you've already assigned, that you've already decided is going to be doing that, and they know who they are. You have a way to contact them. You have, you know, you have it 24/7 staffed. You know who needs to be on the team. That team has a code card. the equipment is located in specific areas. It has a schedule for how it's going to get replaced, so that at any moment if a code is called, you've got the medications you need, you've got the defibrillator you need, you've got the PPE you need sometimes. And that was a big one, starting with COVID-19. All of this is just massive amount of investment in a system to prevent somebody from dying from a cardiac arrest, right? And do we do the same for infection prevention, right? Where is the emergency number for infection prevention? Do we have that contact? Do we have that contact, do we have that resource of somebody who's going to coordinate a response? Do we have the supplies that are needed to respond to infection prevention problems? Where are they? Are they managed? Who's in charge, right? And do they know, right? This goes back to assigning roles, but it's much larger than that. Where's your PPE? Who gets it? Who stocks it? Who keeps it handy? And all of those things are, part of the system. So you can say to everybody, you should be cleaning your hands, but if 30% of your hand dispensers are empty and don't have alcohol hand sanitizer in them at any given point in time, your problem isn't the behavior of your employees, and your problem isn't the culture of hand hygiene. Your problem is the system that refills your hand sanitizer. So think really critically about this middle piece, this systems piece, because I actually think, even though it's kind of in the middle of all of this, I really think it's one of the most neglected and yet most important parts of this entire thing. We spend a lot of time talking about behavior, and that's absolutely valid, but without systems, behavior is something that will not change. You can't educate things out of people. That's not to say that education isn't important. Don't get me wrong. This is Project Firstline after all. It's incredibly important. But systems are integral to that, and they shouldn't be neglected.
Mm-hmm. Agreed. Yeah, and I think, Abby, just to bounce off of that last comment too, I mean, action, education is so important. We have to start with the knowledge, but then moving from knowledge to action, it takes effort. And I think, I highlighted the AHA team training or the TeamSTEPPS toolkit at the beginning. I mean, that was why we invested in creating that easy-to-use tool, because having some communication skills to sit alongside the infection prevention knowledge will help you to act and support your team to act as well, because it's not just having it in your brain. And I think the other thing that I take too is like the joy and the magic from my point of view about healthcare is because humans are involved. But humans are involved, and we are not perfect, and we come to every situation with so many things happening in front of us. And so to your point of really paying attention to those systems, like what can we do? How can we critically think about this and approach it in maybe a different way so that we can help everybody to do the right thing? Because I think genuinely people in healthcare come to do the right thing. They really are there for the patients. I think we've seen that in the comments too. So really, what can we do differently? And to also some of the comments that we had seen earlier is really help people to have this as a priority all of the time. I mean, day in and day out, being on guard all the time is just not realistic. And so how can we support individuals to really do the right thing so that they are successful in what they came to work to do?
Yeah, and behavior change, as you all know, is just another huge topic of issue. I think one of the things when you look at how people cognitively process things, right? So there are many theories of cognitive processing and messaging and behaviors and whatnot. But essentially, there's sort of two tracks of cognitive processing, one of which is very automated, right? You can drive your car without thinking about, okay, hands on the wheel, okay, now I turn the key and I wait for the sound that the engine has started, and then I release the key. You can tell I drive a very old car. And then I press myself. You don't think through any of that, right? At some point, you get a license and you drive enough that is an automatic series of events that you perform every time you get in a car. But that doesn't mean you're not paying attention to driving the car. It's very automated. But that took a long time to learn. Ultimately, a lot of infection control should fall under that cognitive processing pathway. Something that's very automated, very easy to go through without much cognitive thought. And I talk about them as healthy habits in some of our Project Firstline stuff, but I really think of it that way. Like, these are just healthy healthcare habits, healthy infection control habits. Pushing on the alcohol dispenser every time you walk into a room, it's just a habit. If I see a dispenser and I'm walking through a doorway, that's what I do. It's automated. I don't even think about it. So that's cognitive processing lane number one. Cognitive processing lane number two is much more complex and harder, and that is the aware processing of things. And humans have a hard time doing that, even though we do it a lot. Medical care requires that we do it a lot, and it's exhausting. So it's very hard to do. And I think one of the errors that we sometimes make in infection control is we tell people that they should be doing this cognitive processing, paying attention thing all the time, every time, when it's biologically not possible, right? So again, systems are there to help make that first lane of processing, the automated processing, the preferred lane of processing at all times. But then you have to sort of say, okay, well, how do I help all of my healthcare workers understand the time when they have to kind of think actively about what is going on and what should be done for infection control? The answer to that is much larger than we have time for in this. But this is what Project Firstline is essentially trying to do with our curriculum. In the next year, as you will see, we'll be talking a lot more about how do you teach healthcare workers to recognize risk, and then what they do about those risks. But, if you think about it, again, from a code perspective, what do you tell employees about code? Everybody gets code training in their new employee orientation. What do we tell them? If you're concerned, call a code. That's basically what we say. You see somebody down and they're not responding, call a code. You see somebody that looks like they're having trouble and you're worried about them, call a code. Somebody faints, call a code, right? And the message to people who are not diagnosticians is, yeah, you don't have the knowledge. You don't know. That's okay. You as a human being can recognize that somebody might be in distress. And if you aren't sure, call the code. And I think we need to figure out in infection control, what's the equivalent, right? If you aren't sure, what do you do, right? And what sorts of things should you be looking out for? What sorts of things should set off your alarm bells? In the world of COVID, it's pretty easy. If somebody's coughing a lot or they've got the sniffles, people start going, oh, you look sick, right? I look at somebody and be like, I don't know if I want to be close to you. That's a very layperson reaction to people looking sick. We all kind of know what that looks like. Doesn't mean we're going to catch everybody, but if you see that, do your employees know what you should do? Do they know where to go? Do they know what that means and who to talk to about it? Because that's something every one of our employees can recognize, if every one of us can recognize, but there may not be a system in place to deal with it. And they may not know what actions they need to take to prevent the infection from spreading. They've identified it, but the rest of it is missing. So I think it really actually is diagnostic thinking for those of you who are in that world. And it's teaching a form of diagnostic thinking to people in a really straightforward way. And Stephanie, to answer your question about how old Project Firstline is, it is a year and a couple of months. a year and 2 months, maybe, at this point. It's very new. It was born out of COVID. It's been in thought process stage for a while. Mike Bell, our boss, has been wanting to do this for a long time, but COVID really pushed the issue and said it needs to be done, it needs to be done now, and so that's how it came about.
Yep. So I think I'm going to pause us. We've been answering questions throughout, but I just want to pause and see if we want to actually do some specific Q&As.
Yeah, Kristen, this is Jen. Thanks so much, both Kristen and Abby, for that really informative discussion. It's definitely a different format that we've done here on our webinars, and it was really enjoyable, and I got a lot out of it too, so thank you. We have about a little less than 10 minutes left. We might be able to sneak in a couple of questions and then wrap up with some closing remarks and just housekeeping. But I'll kick this off with, you guys, talked earlier about drift and normalized deviants, and so this question kind of falls under that. So during, the crisis level acuity and staffing that was associated with COVID surges, corners were cut out of necessity, and so it kind of seems like this has become the new normal. Kristen, I know you said to involve staff to help understand the why from the beginning, but do you guys have other recommendations for reinforcing the back to the basics to prevent like HAIs and pressure injuries and that run the gamut there?
Yeah, I mean, Jen, that is a huge question. I've actually heard that from a number of individuals across all of the different work that we've done. I think one answer is not going to create a solution. It really does come from a lot of different efforts. I think, some of the things that Abby talked about earlier is like how are we reinforcing behaviors and or reminding individuals of the behaviors that are expected. I think during the COVID, really when we were at such a strong peak, there were so many issues with supply chain and different things that created a different environment than we are currently in now. And so how do we move people from that crisis mode, changes that happened on the day-to-day basis, and now moving back to that, the new normal. And I guess also, too, as Abby had said, is all of us to think hard of what we're doing. Could we create an even better normal? Abby, I want to open it up to you if you have any, concrete recommendations.
Yeah, no, I think the first thing I would say from a sort of science and QI brain standpoint is you take a look at the literature on de-implementation, because that's essentially what you're talking about, right? And a lot of that literature will essentially say de-implementation is harder than implementation in a lot of ways. But that's what we're trying to do. We're trying to de-implement something. I think another frame of mind to put your providers in is that we went to something that is not standard of care, that is below our usual quality, right? Mm-hmm. And so by clearly identifying what the change was, and that change was part of crisis standards of care, then you can say, this is below quality behavior, below recommended behavior, below recommended care. We do not want to give suboptimal care. We need to go back to the standards of care that we used to be at. And I think that helps push people along. The third thing that I was going to say about the implementation is that, I remember, there is a paper that was published in Induction Control and Hospital Epidemiology by NHSN and its associated team, I think a couple of months ago now, basically showing that healthcare-associated infections across multiple infection types, across hospitals nationwide, rates went up. And there were some that didn't, so surprisingly C.diff did not, although that may actually not be surprising given cleaning and disinfection protocols. But so lots of different information in that paper. Highly recommended. I wish I could tell you the name of the first author off the top of my head, but I don't have it at the tip of my tongue. But it is within the last couple of months. I think if you search like IHCE healthcare-associated infections, CDC, you should be able to come across that. And if I find the link for closing up, I'll try to put it in the chat. So those would be the three things off the top of my head that I would say, getting back to normal, I would use those things.
Mm-hmm.
Awesome. Thanks, Abby and Kristen, for answering that question. I want to allow time for some closing remarks. So we'll kind of stop this portion of the conversation in the Q&A, and then, Abby, I'll turn it back over to you.
So infection control, just to give our key takeaways, infection control is the actions we take, the systems that we put in place, and the culture of shared responsibility that we develop to prevent and stop the spread of infections in healthcare. And then we really want to emphasize here that successful infection prevention is a whole team effort, and that the whole team needs to have the knowledge and the skills that they need to keep both themselves and their patients safe, and that this really is everybody in that building is a patient. That includes the staff. They are caring for themselves, for their colleagues, and for their patients all at once by engaging in infection prevention and control. Next slide, I think I'm turning it over to Kristen.
Yep, and just to close this up real quickly, here are some links. I really encourage you all to look at the CDC Project Firstline resources as well as the AHA Project Firstline resources. We have information that you could sign up for different newsletters on both of those web pages and such. So really, if we want to continue this engagement, we'd love to have you. And then Jen had mentioned this early on, but just as a reminder that the ACC conference is happening real soon, so go ahead and sign up, and there are scholarships available. And I'll turn it back to Jen.
Thank you. And I just want to once again thank Kristen and Abby for a really great, not only presentation, but a discussion, which was very refreshing to listen to today. So just a few final reminders. You'll receive an evaluation sent to your email here shortly. We really value your feedback, so please complete that when you can. Finally, to receive continuing education for today, please text MARPUK to the number you see there on the screen within the next 24 hours to claim your credit. As always, you can email us at teamtraining@aha.org if you have any questions. But I just want to say thank you again, everyone. We hope you enjoy the holidays and the end of the year, and we will see you again next month, January 12th. So thank you again, and enjoy the rest of your day.